And I will start sharing my screen. And I'll turn the mic over to you, Dr. Cowan.
Okay, thank you. So we're starting again with session 1 of asthma self-management education course. Next slide. This is our monitoring slide that lets us know that Karen and Melissa Barron is our nurse asthma educator in our clinic, who will be one of our speakers. We have no conflicts. This course is approved for 1 credit for nurses and physician credits, and you can claim those by going to the UVM website. And I think that those of you who have been on previously have gotten that from Karen. If not, if you could put your information in the chat that we can send that link to you. It's pretty straightforward once you've logged in to claim credits. Before, it's pretty easy to do. They ask to try to claim the credit within 30 days of each session. They are up longer, but it's easiest to keep track if you claim in 30 days.
Also, Dr. Cowan, I just wanted to mention that we'll be sending out the links to all the prior 4 recordings, possibly this one as well, but the first round, those links will be available through the school nurse newsletter after this Friday. It'll go out by Caitlin this Friday.
So you'll see on the recordings, there'll be 4 sessions and then they'll repeat again. We'll get to the next slide and I'll go through what those are. So the objectives overall of these 4 sessions are reinforcing the skills and knowledge foundation around asthma self-management education, and then being able to identify children who have suboptimal asthma control and to be able to apply that session content to provide education in a developmentally appropriate way for children and their families, and to be able to apply these tools to deliver asthma self-management education to at least 1 student as part of reinforcing those skills and improving care for those children. Throughout these pieces, we incorporate the 2020 NHLBI asthma guideline updates. We'll talk about how to do an Envision walkthrough at your school, have you be able to get your school nominated for asthma friendly school recognition. And then as we go through, if you have any cases you'd like to discuss or questions, even if it's not the topic of the session, please have those ready and we can go through any case discussion or questions that you would like. Next slide. So we're starting back at session 1. I'm going to talk about an asthma overview and asthma basics, pathophysiology of asthma. Recognize it's still a fairly dense topic, but we'll go through those as more the foundational skills. And then for those of you that are working with a student and applied work here, then think about starting, if you haven't already, with your handouts from Karen, starting asthma self-management education with the student that seems to have lower asthma control, working on filling out the top section of the participant form, working on an asthma control test with the student, and then the video links from Karen. The asthma basics one would be what pairs with this presentation about asthma basics and pathophysiology.
And just to mention, if someone is on the call that hasn't received that packet, just put your email address and ask for the Ask Me in Schools packet, and I'll be glad to send it to you.
And I'm going to turn over slides, I think, to you, Karen, as we go through our first session, talking about asthma prevalence and some of the epidemiology for asthma. And we can you can unmute and ask questions or put it in the chat if you have questions as we go along.
Yeah, thank you. So I know you all are on the front lines and probably deal with a whole slew of items and topics and health concerns as you work and work with your kids in schools. But asthma is we kind of rank high in the country for asthma prevalence. We have about 9,000 children that have current asthma. We are in the top 5 states with highest asthma rates. So a lot of families are impacted by asthma. So it's likely a common topic that you face daily. We know that there are some pockets of folks who are bearing that burden of asthma more than other Vermonters. Those that have low socioeconomic status, lower education status, Medicaid insured, which overlaps a bit with those two, those who live in older or poor housing stock, renters, folks who are in multi-unit housing, and other certain housing circumstances, as if they're on a major roadway, for example, where there's a lot of dust or diesel air quality impacts. We know that there are other concentrations of asthma in regional hotspots. Families who have struggle around secondhand smoke exposures or have family members who smoke or vape. We know that in Vermont, there's a lot of individuals who have asthma who also smoke and vape, which is a high rate for across the country. And we know that there are certain occupations that are vulnerable, those who have high time in their homes tend to be those with higher burden. So those with disabilities or other complex comorbid chronic conditions, and those who are unable to work or work in the house have higher burden of asthma. So we're talking about 1 in 12 kids who have current asthma. What concerns me a lot is out of all of these children, even those who are being treated for some reason, we still have a very high rate of those with uncontrolled asthma. So that's about 61% of Vermont children with uncontrolled asthma. This translates into a lot of missed school days, 1 in 3. Activity limitations. Every 1 in 2 kids aren't able to fully play the way they want or do whatever activities they want to do. And 1 in 6 actually have sleep disruption, which means they have a harder time concentrating in school. They might be irritable. They may not feel good. They may not learn as well because they're not concentrating. 51% of the children have had an exacerbation in the past year, and this means that they're at higher risk of other adverse costly events, including hospitalizations and ED visits due to asthma. What are indications of uncontrolled asthma? You know your kids, you know when they're having trouble. They may have had 1 or more ED visits, urgent care visits, or hospitalizations for asthma in the past year. They may have had 2 or more primary care office visits for asthma symptoms. If you use a objective test, like the asthma control test, if it shows poor control about 2 times a year, this is a sign of having trouble keeping asthma under control. If they are using a course of oral steroids for greater than once in the past year, that's also an indication. And there may be exacerbations that might be triggered by exercise, extreme cold or heat, allergy seasons, certain air quality exposures, fragrances, scented products, and other common personal triggers. All these are indications of uncontrolled asthma. And one thing we have discovered is a way to support, in addition to their working with their doctors on a treatment plan and carrying out their plan. Those with struggles with uncontrolled asthma can benefit greatly if they're given what's called a asthma self-management education, ASME. This is more intensive supplementary education. It involves a focus of, it's usually a supplementary above and beyond your standard doctor education, doctor visit. And so it usually focuses on 4 content areas. We are using those content areas to structure these sessions. So focuses on an overview, the asthma basics of asthma pathophysiology, then the medications, triggers, and daily management. And they focus on mostly 2 elements: knowledge, but not knowledge alone. It's knowledge together with the skill development and reinforcement that makes these ASME effective. And it is shown to improve and sustain asthma control for up to 1, 3, 6, 12 months even, we've seen. And so it's really great for those that have uncontrolled asthma or these high risk kids. Is this how far you wanted me to go? Keep going. Keep going. So if you are interested in, we challenge you to take it upon yourself to deliver ASME to at least one child or student with uncontrolled asthma. And we've provided that packet called the ASME in Schools packet, and it provides a checklist of content, and or we make available to you links to videos where you can show these videos. They're 5-minute videos on each of these 4 topics, and you do this in at least 2 sessions so that their brain can absorb this much information, not all at once, but at least two to 3, possibly even more sessions. But you can do it in 2 sessions, and then you kind of just document a little bit of you do a quick assessment. Sorry, covered those topics, right? And there's these 4 videos. In addition to those 4 content videos, there's 2 demo videos on how to use proper inhaler use. So this is content knowledge on these 4 topics, but there's skills in properly using your device, properly following an asthma action plan. And so these videos are also available in other languages, and we hope to expand that in the future. And we can provide technical support to you one-on-one, in a group, if you want to do it regionally, to know how to go about delivering ASME to a group of kids with uncontrolled asthma. But we challenge you to try at least to do it with at least one student. You can then turn around and get points for doing that through the Asthma Friendly Schools program. And we encourage you to apply for that or nominate your school accordingly. So to kind of track improvement, there's 2 things that we ask you to do. There are other metrics you can track improvement, but we try to just focus on improvement using in asthma control, using the asthma control test. And there's a nice little link here to a tool that pulls up and shows you a meter after answering these 5 questions with the student. And then there is a assessment of whether the student knows how to use their device properly. So you have them use it and you assess whether they're timing it properly, whether they're taking it in, if they're using a spacer, things like that. And we have shared some links to YouTube videos of proper device use, given all the variety of devices. We can make those available to you if you haven't seen those links. And then you just document, what's your school information here, some de-identified information on the student, and some basic observations you made that suggest that they were uncontrolled before you started. And then you just have there's just this small little element down here that shares which of the educational sessions you delivered and what date, and what was their assessment in asthma control, and what was their, were they using the device properly or not before you started education. And then you give them coaching about how to improve their technique if they're not using it properly. And then maybe after you're done, you do an assessment again to see if there's any improvement. And you send me those forms, and that can count as towards your asthma-friendly school recognition. The results are pretty good. This is an example of some of the post data that we used just based on school nurse delivery of asthma to students. And you can see that the blue is the pre, the turquoise blue is the pre-assessment. And so 39% had poorly controlled asthma of the students who were selected by school nurses. And then by the time they were done, only 25% had poorly improved. So there was an improvement amongst those students. There was a pre-test that showed 74% did use their spacer. By the time they were done, 100% used spacers. And then they had 64% only who could use their inhaler correctly. By the end, they almost reached 100% who could use their inhaler correctly, meaning they were getting medications to their lungs more effectively. That's covered. Again, skills and knowledge is key. And if you are interested and you want to give this a go, please reach out and I can get you that packet, then turn around and nominate your school for asthma-friendly recognition. That's very easy. You click on this link and you would find this particular page, and it would lead to a quick survey of your name, the school information, and then a list of all these different possible best practices. And if you don't know, you just click on I don't know. If you have to interrupt it and go on, quickly just, complete it and get out and then go back in and you can continue your nomination again. I don't believe you can continue. I think you have to start again, but just put, question, and then I'll combine them at the end so you can have a complete form if it takes 2 or 3 sessions, or if you have another staff person who wants to complete it and nominate because they know something about like grounds and facilities, you can do that and get even more points. So that's about it from my side. Dr. Cowan, why don't you take it back?
Thanks, Karen. So we'll move on to talk about pathophysiology of asthma. And the NHLBI defines asthma as a chronic inflammatory disorder of the airways. There's recurrent or persistent episodes, and these are associated with variable airflow obstruction, bronchial hyperresponsiveness to a variety of stimuli. Next slide. And a lot of pieces go into asthma care, and this is from the 2007 NHLBI guidelines, which still stand in addition to the 2020 updates. But these are the actions that we take through clinic and caring for kids with asthma for asthma healthcare delivery. And one of the important components, as Karen was highlighting, is providing routine education on patient asthma self-management. Next slide. I know Karen has shared some resources for teaching, and there's probably a fair amount of things that you already use in terms of teaching. So if there's things that you found particularly helpful, we'd love to know what works for your students and for you when you're teaching. This is one I'm sharing because this is one that I tend to use for parents and older kids when I'm sharing along with a model of the airway, and sometimes just this diagram when I'm teaching on the inpatient unit and in clinic about what's happening with asthma and how the medications work. This tends to be helpful to me in demonstrating with families because I can't draw. So this cartoon helps me out a lot to be able to demonstrate what a normal airway looks like. And potentially the normal airway could be someone with intermittent asthma as well. And then in the middle, someone with persistent asthma, where you can see here the actual problem is the inflammation in the airway wall. And then you can see during an exacerbation what's happening when the wall becomes even more inflamed. You have tightening of the smooth muscles, you have air trapping of villi, an impairment of being able to fully exhale while you continue to inhale more air and inflate those balloons more. And I think that tends to be a good demonstration of to parents to be able to see what their child's experiencing and relate that to their symptoms. And then also to be able to understand where and how the medications work. And that can be impactful in understanding that and knowing how we achieve some of the goals through the medication and the education. So we talked about on that first slide about the pathophysiology, about the definition of asthma being as having chronic inflammatory disorder, or recurrent or persistent episodes, variable airflow obstruction, bronchial hyperresponsiveness. And this is all based on history. It's not often straightforward, and especially in kids, especially the younger the kids are, the presentation can be variable. And really little kids, we don't have ways to objectively measure lung function. Lung function is typically normal if kids are not having an exacerbation, and the episodes aren't always consistent, and there can be a variety of triggers, and that can make the clinical picture confusing in some children. Asthma can be diagnosed in infants. Typically, we're seeing the pattern there first before making that diagnosis. So sometimes that becomes apparent with the first flare, but often until we see that pattern, we may not make that determination until at least the second episode or exacerbation and figuring out what the cause of the cough or wheeze is. So infants can be challenging, and there are a lot of other comorbid conditions or alternative conditions. Next slide. So for symptoms, we see cough in some kids, wheeze in some kids, and some kids have predominantly cough, some kids have predominantly wheeze, some kids have both. Could have shortness of breath, exercise intolerance, chest tightness, prolonged colds, recurrent pneumonia. And then for signs that we can see if the child's well, often the exam is normal. If they're sick with an asthma flare, they can have tachypnea, wheeze, decreased aeration, retractions, prolonged exhalation, and increased AP diameter of the chest. And there's a lot goes into figuring out differential diagnosis. So is it just asthma? Are there other conditions that are alternatives, or other comorbid conditions that are making the asthma worse? So those are things that we think through as part of the diagnostic process. Next slide. And as far as natural history, this, as you know, can be variable. For most kids, it begins early in life. Although it's not unusual for us to see the first presentation in a middle schooler or high schooler, so that's also not unusual. But for most kids overall, this tends to start earlier in life. Most who wheeze before age 3 don't have ongoing symptoms after school age. The risk factors for kids having persistent asthma is allergy, eczema, recurrent wheeze, and parental history of asthma. We do see an increased risk with prematurity and increased risk with tobacco smoke exposure. As far as early exposures, we have things like hygiene hypothesis, where early endotoxin exposure can preserve a Th1 response and avoid a switch to Th2 or allergic response. Next slide. Common triggers for asthma, as you know, the more common things: viral infection, smoke exposure, whether that be tobacco smoke, wood smoke, smoke in the air, and exercise most common, and then allergens, air pollution, other chemicals or dust in the air. Those are the next most common. So that can be variable, and that can change seasonally for kids. Next slide. Kind of spend a little bit of time on viral infections here because you're dealing with this a lot at school. And viral infections, rhinovirus would be a prime example of this, but other viruses commonly do this as well. These can predispose kids to developing asthma and trigger exacerbations. RSV, we know, is a risk factor recurrent wheeze in young children, and there's an increased risk of recurrent wheeze if there's a positive family history of asthma. Not a risk factor for kids as they get quite a bit older, but in early life it is. For a non-RSV infection, this is strongly associated with increased risk of recurrent wheezing and asthma, and with kids who wheeze early on with rhinovirus being a significant predictor of asthma as they go through childhood into adulthood. Slide. So common problems with these recurrent viral infections during the cold season is airway hyperresponsiveness. The duration of airway hyperresponsiveness after a single cold can be 5 to 11 weeks. After multiple colds, the airway can remain responsive for more than 6 months, and the prolongation of viral-induced airway hyperresponsiveness in atopic children can contribute to asthma persistence. So this is a pretty common problem we see during the cold season, is that not every cold is necessarily problematic for asthma. Sometimes the right virus, if it set off the asthma, that can leave the airway really irritable for weeks or months after. And then, or after several colds, the airway can be irritable for weeks or months after. So when we, often kids are taking breaks from maintenance therapies in the summer, and this is one of the reasons during the cold season that for kids who are sensitive to this problem, we really focus on adherence to maintenance medications during the school year because of the repeat viral exposures and not wanting to be chasing the problem by calming down the inflammation for a few weeks, stopping it, and then getting into that same cycle. So this is the rationale for focusing on that during the cold season. Mentioned about differential diagnosis, contributing conditions. So pretty common that kids with asthma have other comorbid conditions that we need to think about. So big ones being allergic or environmental triggers, deciding whether need allergist referral, allergy testing, environmental controls that we can recommend for their particular triggers. And then smoking would be another big one, either for children who are exposed from parents or caregivers, or children who have smoking, vaping exposure themselves, can definitely contribute to poor asthma control. Fine. And come back to testing a little bit, how we talked about this being a clinical diagnosis. So this is an example of often get chest x-rays for chest conditions. And I do often get an x-ray in if kids are having first asthma flare, the history is a little bit unclear. Often to confirm normal or look for major anatomic issues, but this is showing a demonstration of a non-specific chest x-ray. So this is, both of these are a really common appearance of what the chest exam on the x-ray looks like during a cold with asthma exacerbation. You can get some hyperinflation of the airway, you can get some hazy markings there, it's kind of dirty, just from having junkiness from a viral infection. But these two films look exactly the same as you would see with a child who had chronic aspiration or a child with cystic fibrosis. So this really is not distinguishable for any particular condition when we see those findings on the x-ray. So there's not something specific you see on the x-ray, although you might say, yeah, it's consistent with asthma, but it doesn't tell you that's what it is. Still have to take the history. Fine. And what do we do for testing for kids? So infants and young children don't have a great way to do that. The one I have starred here is spirometry. This is testing we do for older kids in our office. And this is the best way of measurement. It's reliable. You have to be skilled in interpretation of it, but it's fairly straightforward all in all. I'll show a little more on the next slide. I'll mention two other measures. Exhaled nitric oxide, or FeNO, I mentioned because this is included in the asthma guideline updates about how to use this. And this measurement can predict steroid responsiveness in atopic patients. It can be less useful for non-atopic disease. It's expensive to do. Even in our clinics, kind of hard to get in for that test. There's not a lot of availability. Sometimes the machine is down. Overall, it's pretty helpful, but it's not the mainstay of treatment. The history is still more important in guiding therapy. And then peak flow measurements, this is something that can be done at home. It's not expensive. The trouble with this is you're breathing into a small device. It depends on the device, the effort of the patient, and then you have to do that consistently. So the device has to be used twice a day over time to get repeat measurements to see how that changes, or if you're sensitive to getting a flare, that might give you some information early. But in general, this has fallen out of favor. This is something that I would really rather people focus on taking their maintenance medications and measuring this at home, because it's really not as reliable or helpful. For a select group of patients who have poor symptom perception, or who are really motivated to do that and have something they may detect early, that can be helpful. But this wouldn't tell me any differently whether someone's having an exacerbation or not. That would still be by history and exam. But for the select patients, it might be helpful. But this is something you don't see, it's something everyone needs to have. Next slide. So we'll talk about spirometry, the main measurement that we use, and what does that look like when someone has poorly controlled asthma. It can be normal, so we can still go by symptoms, but what we tend to see with asthma is that this picture on the left, that's a normal airway, everything's wide open. The picture on the right is a swollen and inflamed airway, and you can see when the airflow is having more difficulty getting out on the exhale, you see this scooped shape in the exhalation. If you see this, the yellow graph, the blue box, and then where Karen's pointer is, the loop that is yellow in that blue box. As you breathe up and you exhale, that looks more like a ski slope than a triangle there, and that is expiratory airflow obstruction. And when you see these two graphs on the very bottom in the black and white, there's one that says pre-bronchodilator and post-bronchodilator. This would be before and after albuterol. That shows what happens when you relax those muscles. So that's just treating the symptoms, the tightening up. It doesn't treat the inflammation in the airway, but you can see where that normalizes. And that would be a classic pattern of poorly controlled asthma improving, or someone who's sick with an exacerbation with that improving after albuterol. Next slide. And then when we're thinking about treatment of asthma, we classify severity. So the severity as the intrinsic intensity of the disease, and that can vary over time. So we definitely see kids who can vary over time from mild persistent asthma, moderate persistent asthma, severe persistent asthma. And initially this is measured most cleanly if it's an initial presentation when they're not on medication already, and that would guide treatment decisions we make in clinic about how much, what dose of medication, how often. And then once they're on therapy, correlate the severity with what's the lowest level of treatment to maintain control. And the important thing to know here is that the severity does not correlate with the intensity of exacerbations. You might have someone listed as mild persistent asthma. It doesn't mean that they couldn't have a severe exacerbation with a cold, but that the mild persistent asthma would describe their intrinsic intensity of disease, even though they could have a more severe exacerbation. And then when we think about the domains of asthma severity and asthma control, we think about impairment, and that's the frequency intensity of symptoms and functional limitation. And then the risk, and that's the likelihood of exacerbation, likelihood of decline in lung function, and then reduced lung growth, and then side effects of medications would be part of risk of treatment. Next slide. So I'm going to just kind of flip through 4 of these slides that just demonstrate what, with experience in doing and treating kids with this becomes a little more internal, but in thinking through, well, how are they assigning impairment, risk, and then what medication to start with. There are tables that go on to describe this. This is how we initiate therapy in kids ages 0 to 4 and ages 5 to 11, and how to classify by intermittent asthma or mild, moderate, or severe persistent asthma. And I think in describing more what's intermittent asthma and what's persistent asthma is when the impairment and risk of symptoms are to a degree where kids need maintenance medication. So they need something every day to keep things under control and treat the underlying problem. And intermittent asthma is when essentially the kids who are just on albuterol for short term, and things aren't as severe with exacerbations. So intermittent and persistent asthma, and then based on the highest level of symptoms in those categories would help classify that. So no need to memorize these tables, but know they're there, and this is where kids move along and doing more or less therapy, and then how to classify their asthma. And we can roll through the next slide, Karen. Yeah, so this again is for assessing control and adjusting therapy. And then when we go to the next one, we're looking at classifying severity in those over 12. And then in this one, classifying asthma control in the last one. So this is a lot of dense material here, no need to memorize, but this is where we kind of align the treatment choices with the severity of symptoms. And overall, next slide, the goal here is in the assessment and monitoring, is to reduce the impairment and risk. So the control would be, are they having less symptoms, and are they meeting the goals of therapy? And once they're on treatment, this is where we maintain or adjust therapy, which might include a trial off-med medication at some times. And this would be the time when we go over with families what the goals of treatment are. So what are the symptoms that we're looking to reduce? What are the quality of life issues that we're looking to improve? And then what are the adverse events that we want to avoid? Okay. So mainly when we think about adherence and control of asthma, there's a lot of factors that affect that. Mainly they're social things. So what is happening in the family around the child that affects their control. So does the child or family have depression, stress, or anxiety? Those are medical issues that can affect the child, even if it's the caregiver. Then it may be the child themselves. Do they have exposure to tobacco or other substance use? Safety in the home, food security, whether there's multiple homes or caregivers. Big one we see is the appropriate level of supervision and assistance for medications for kids, especially in the elementary school age, as kids become more capable of doing their own, making their own food, getting their teeth brushed, getting dressed. Their medication supervision still needs to happen. And that's something that's pretty developmentally normal to drop off, and families still need to supervise, but it can be hard for families to recognize that when kids are doing so much more on their own. We see a lot of issues with barriers to obtaining medications. I think that's probably one of the bigger difficulties that we have in clinic currently is insurance issues with medications, and what the cost is with their deductible or what their insurance is willing to cover has been a big deal this year more than others. And then sometimes it's issues with transportation to the pharmacy, if the pharmacy has a delay in when they have the medication available, when they're going to have a refill ready. Those have been big barriers even for pretty motivated families, and that's been quite difficult to navigate. Schedule of medications can play a big role. If there's changes in the environment, caregivers, school, work, those things can affect the child's schedule and get things off for them. Medication beliefs on the part of the parent or the child, and those can be worries about side effects. Those can be, I think my kid's doing well right now. Do they need it? And then for them to know when they can to really follow up and be able to reach out with those questions so that we can know maybe the child is doing well for an extended time, and is that an okay time to take a pause from medications, or are they having side effects or things you're worried about, and we can do something about that and make it better so you can take your medications. And then we think about sometimes as well whether it would help the child to have any medications administered at school. We have a good number of really grateful families where that's been pretty life-changing for their child to be able to do that. And then we try to check their medications and devices, make sure the technique is good, and then checking their refill history to make sure that they're getting what we think that they're getting. Next slide. And then factors associated with the increased risk of exacerbations or death is if they have severe airflow obstruction on spirometry, more than 2 ED visits or hospitalizations in the past year, a history of intubation or ICU admission, certain demographics, and the bigger ones are kids who are not on inhaled corticosteroids or have who are currently smoking, and then psychosocial factors, and then attitudes and beliefs about taking medications. Slide. So I'll turn back over to Karen for a couple slides, and we'll have time for discussion.
Yeah, so again, this is just a reiteration that, after hearing the content of the asthma pathophysiology from Dr. Cowan, and some of the symptoms and signs and observations you've had about those with uncontrolled asthma. Again, we recommend you try delivering ASME. And if you need the packet, please send me an message that says you haven't received it or you need another one. And I'll be glad to do it. Just make sure I have your email and put that in the chat. If you've delivered ASME, I would love to hear from you and see how it went. And then otherwise, I'll just open up the floor. The only other slide is this slide on restating the impact of improvement in asthma control as a result of delivering ASME in 2 to more sessions, and the improvement in inhaler technique. And that's it. Otherwise, I'd open it to questions on either the pathophysiology of asthma or sharing of any examples you've had of trying to deliver ASME or other issues related to asthma, some of your major challenges in addressing asthma. Not all of you here are school nurses, so other systems issues you notice or any reports you might have from those in your region. So Dr. Count, I was just curious about the how often you see the connection between what is it, eczema and asthma in kids? Is that a common challenge?
It's common for it is a risk factor for children who have asthma. It's a risk factor for persistent asthma. If they personally have eczema or allergies, then that's more common than kids who don't.
Do they often have it like around the ears or the nose where it's painful?
No, the certain spot, the flexural areas are really common. So the inside the elbows, behind the knees, face, ears, hands. Those would be common as well. But that's not everyone who has eczema has asthma. Not everyone who has asthma has eczema, but it is a risk factor for persistent asthma in a similar way as allergies.
Yeah, because just a curiosity, because we do measure that population data on quality of life and limitations, activity limitations, sleep disruptions, but we don't collect data on discomfort or other kinds of, that kind of quality of life concerns, but I guess there are some of those things as well. Anxiety, we do anxiety and depression, but yeah, I just wondered about the skin related connection.
Yeah, it's not everyone who has it. And it's a great question I'm sure there's others know more about, like just quality of life overall with eczema. But I think, I do think kids experience a lot and their parents may not know if they don't have that themselves. It might be hard to know that how itchy or, that is, or how, impaired their sleep may be or those things. But yeah, you can't assume that everyone is having that problem who has asthma, but if they have eczema as well, then that's a risk factor, and it makes, if they have persistent asthma, that's not unusual to see that they have that.
Would that be similar about GERD, gastrointestinal? Do you see that more in adults?
No, I mean, we see that in kids too, and that, is something we talk about is that, do they have comorbid symptoms that they need to be treated? But treating reflux does not get rid of asthma. Sometimes it's a comorbid condition that might need to be treated, and everyone's symptoms would be a little bit different for that to consider.
Well, thank
But
you.
not everyone with asthma needs reflux medication.
I see. Yeah, thank you. Any other questions, or anyone want to share anything about their connection to asthma in recent days?
So I would just say, this is Kim. I just want to say, in terms of challenges, I think one of the biggest challenges is getting our parents educated, right? They get the initial prescription. Sometimes they're really good about following up. Sometimes they're following an asthma action plan. Most often not. It's kind of, it feels like to me that the time that the parents engage with an asthma action plan is when I ask for it every year. So yeah. So, and too, I think one of the reasons I'm doing a broad approach and maybe not quite as narrow as one-on-one with children is maybe my sense that parents are not receptive to that kind of detailed work at school for some reason. You know what I mean? So I've been delivering education to the kids, but I'm hesitant to really kind of walk them through their self-evaluation kind of thing. Because yeah, I think parents would question that, at least in my school. So
Yeah, I think you know best about your school and what works and for who, and also I think sometimes with the asthma control too, that some parents might be interested in that as a resource for themselves to look at too.
right.
Even if it didn't seem like it was something in the moment. And there's been, I know with one session I'd participated in, at one point, someone had a case about just a child at school was having, more symptoms and things, and they had shared, some things with the parent and said, let me know if you want me to, do this and send it to your doctor's office, or let me know if you want me to keep track of this, or how many times they came in, and share that, with the release or something. And that was a solution for that child. It may not be a one size fits all, but it was an interesting solution to me. I would like to hear, if they're having that kind of trouble. I was thinking about this a little more lately about the, challenges with educating parents. That's what we do in clinic, right? So we have kids that kind of fall out of that because they haven't come to clinic, and that, but mostly kids are pretty wrapped in. And I know that's not the case because a lot of people are just calling to get their action plan when you ask, right? And they might not be getting a lot of other education. But I do think of some kids who have fallen off, who are getting a little bit older, and thinking about how is that going to impact them when they need to be independent with their asthma care. Because I have some teens, they're like, their parents are probably taking decent care of their asthma and taking them in for flares and trying to get them to take their medication, but they're not coming to any follow-up. And I think over the next couple of years, they would have to be wanting to do that when they've never had to do it in their life. That's a really hard thing to learn when you're starting to college. Like, why would I have to go to the doctor for that when my parents never took me?
Right.
I'm really kind of struggling with that lately, Kim. So I was like, I started like kind of a couple patients that come to mind. I was like, it's really like kind of affected how I'm going to approach a couple of these kids. Of like, you need to because your kids got to know it's important.
And it's a great question. The data does show that if you educate the parents using that ASME curriculum, just like you would the patient, you can get the same impact on control. So perhaps, I mean, Melissa and I tried this last year, a couple of years back, I guess, using those videos with parents of small kids. And we were able to see some improved control with some of them. So it is a possibility. Kim, you could share the links and kind of treat it as, we're doing this class, and here, watch these two, and do it in like, here, group one of the content, and send links to 1 and 2. And then here's 2, content 3 and 4. and have them fill out that form on their asthma control. We know that parents tend to overestimate how kids are doing than they really are. But that might be one approach you could do in terms of parent education. They're only 5-minute videos each, so it'd be like a 10-minute harassment of parents, if you will.
That's a good description.
Yeah.
I think
I'd
the
be more
indirect
than happy
approach
to
is
do that.
sometimes good. The indirect can work too. There's been some times where I feel like that the child's old enough, like is interested, it may want to know, and then the parents maybe could use the review, in my opinion, but don't feel that they need the review. And some of those I've shared, like, well, there's some materials they could watch, or you can take a look and see if you think that's appropriate for your child to take a look, because they have these questions and are interested, and it just takes a minute. And or if they're feeling like they need something for grandma or, you know, other caregiver, that sometimes that's been a route for me to like give them a little bit extra because they're sharing it with someone else and they feel like they're empowered in teaching something too.
Yeah, there you go. Those are good ideas.
Indirect. Sometimes I'm going to
Yeah.
teach your child, but you're listening.
Yeah.
Well, listen, we're at the end of our time, but we'd love to hear how it goes, Kim, as you go into, I know you're planning to do it over the May month of this focus on asthma education. So good luck and reach out anytime, and we're glad to provide whatever support we can.
Will do. My first one with the kiddos is May 10th. So,
oh, great.
Yeah. So we'll see how it goes.
Okay, let us know. Yeah.
Or email if you need anything, Kim.
Okay, thanks. Thanks so much.
And then thanks everybody. Thanks for your presentation, Dr. Cowan, and I hope you all have a good week. We'll see you next week to address asthma medications, and a recording and links will be available, and let us know if you have any trouble getting access to claiming your credits. Again, thank you so much. Have a great day.
Bye-bye.
Bye-bye.